Patient autonomy and satisfaction are fundamental components of the healing process. What can we do to ensure that our patients have the best experience possible? In this week's Health Talk, we'll discuss patient centricity and the importance of providing patients with a supportive and positive healing environment. Stay tuned for more with Dr. Richard Kaplon. He's Section Chief of Cardiothoracic Surgery at Danbury Hospital. Hello, I'm Dr. Eric Mazer. On this week's Health Talk, we're going to discuss patient centricity. Our guest is Dr. Richard Kaplon. He's Section Chief of Cardiothoracic Surgery at Danbury Hospital. Richard, it's so great to have you on the show, and
Eric,
great to have you here at New Vance.
great to meet you, and thanks so much for having me.
I said it to you when you walked in the door. You're a cardiothoracic surgeon. I think most of us think they're sort of the apex of the medical practitioners. Maybe you arm wrestle with the neurosurgeons, but you guys are the ape, and yet we don't think of patient satisfaction in the same sentence generally with a cardiovascular surgeon. How did you get interested in the patient experience?
So I think if you look at the evolution of what's gone on in medicine in the past 20 years in cardiac surgery, we've seen the historic silos break down, the distinctions between the interventional cardiologists and the heart surgeons. I don't know that we're apex anymore. I think we're part of a team. And I think that's where the patient centricity element comes in. As we focus on our care from a patient point of view, they don't care what my title is or what my badge says. They don't care what the interventional cardiologist title is. They care about, they want to get better and go home.
Yeah.
And how we use our combined skill sets and our combined expertise to get them the best therapies and get them home is really at the core of what I would call patient centricity.
Now, you mentioned that you're part of a team now. It seems like very much that's the way medicine is going. For a whole host of reasons, it's a whole team of people that care for you. How does that factor into patient satisfaction? I think, particularly our generation remembers Marcus Welby and this wonderful, warm, avuncular physician who took care of everything, and that's a model that people, I think, want to see out of their physician, but in certain ways that's become impossible in the current milieu.
So as you and I had a chance to talk about earlier this morning, the amount of data, the amount of knowledge out there, no one person can manage anymore. Back 150 years ago when you and I trained in medicine, we read a big book and that's all there was to know. But if you look at the growth in available knowledge and to try and keep up with it, it requires a team. It requires people who focus and specialize in certain areas, but then sharing that ability, that knowledge, that perspective with others that intersect, like interventional cardiology and cardiac surgery. What we do every day are very similar, but not the same. And so we both bring skill sets to the table that are necessary for best patient care.
Now, you discussed about medical skills, but how does that then interface with the patient centricity and patient satisfaction, and why is that becoming increasingly important?
So one of the things I've seen throughout my training, throughout my practice in the past 25 years, one of the most common questions I get in my office when I see a patient in the office is they want to know if the patient wants to know if I've spoken with their doctor. Does my doctor know what you're thinking? Does my doctor know the plan? Patients want us to talk to one another. They want us to communicate. They want a team-based approach. So at the very fundamental of patient satisfaction is providers like you and I communicating well. That makes them feel good. And you and I both know that having a patient feel good actually helps in their care. It also helps us improve the quality of their care, because with different perspectives, we can provide better care. And with that, patients are happier with the outcomes that they get.
And what types of changes have you, because I know that you're actively leading this effort, what kind of changes improve patient satisfaction? How do you what kinds of things are you putting in place?
So one of the elements is very much breaking down the silos like we talked about to create true team-based care. I'm also very focused though on the patient experience. If you look at our patients, they're just like you and me. They order from Amazon Prime, they expect things to show up the next day. They're very service-oriented. The processes that we've created in hospitals, the processes that we've created in medicine, very much historically have functioned around the care providers. Patients go here for an x-ray, here to register, here to get their blood drawn, because that's what's convenient for us. They come to my office to see me at 3 o'clock, the cardiologist next Tuesday at 2 o'clock. We haven't integrated that from a patient experience point of view. So when my 84-year-old mom needs to go see a cardiologist and a heart surgeon, do I really want her to have to drive to 2 or 3 different appointments? In an ideal world, she should be able to have some one-stop shopping with a service orientation, like an Amazon Prime. And so part of what we're trying to do at Danbury is redefine those processes so that patients have a single unified experience. They see the interventional cardiologist and the cardiac surgeon in one visit. When they come to the hospital, one of our goals is to recreate their care space. So rather than going to the OR one day, the ICU the next day, a step-down unit a third day, and then to a floor bed, we're trying to create a space where they go to one room after the operating room. It's their ICU bed on Monday, it's their step-down bed on Tuesday. The nurses change, but the space doesn't change. So that when your wife comes to visit you, she doesn't have to go looking around the hospital for you. Little things like that very much redefine the patient experience and hopefully their satisfaction.
You know, a lot of patient satisfaction, in my experience, was also having somebody speak to them as a human being and neither talk down to them, but also not talk over their head. Counter that with the problem in medicine that we are getting busier and busier and expected to see a higher volume of patients by some of these organizations, higher volume of patients in less time. How do you reconcile that, and how do you give that time to individual patients without sort of jeopardizing the whole flow-through, if you will, of patients?
So the flip side of patient satisfaction, I think, is burnout, professional fulfillment for care providers. There's really good data in the professional fulfillment, the well-being space, that talks about infrastructure and support. Yes, we are all being asked to do tasks that don't directly affect patient care. The models have demonstrated, and it's actually financially beneficial, if we provide care providers with the support structure and the infrastructure to unburden their tasks that don't contribute to patient care. So add medical assistants to a primary care physician. We find that they are able to spend more time with patients because they're not having to spend time on their computer or on the phone trying to get insurance approvals. You don't need to do what you and I do to get an insurance approval, usually. So by unburdening those tasks, we can go ahead and, yes, it helps our physicians, but it also allows them more time to communicate.
How was the electronic medical record?
It's a little bit of the black hole.
We could talk about that forever.
Yeah,
because I think
that should be a whole other visit, a whole other segment. I personally think the electronic medical record is great, and I say that. You and I took our phones out of our pockets; they wouldn't go off during this segment. There's not a person I know who doesn't live on their cell phone. We're not opposed to digital technology. We're not opposed to information. It's the platforms and the way they've been developed, and they're getting better. Those days are coming. So I wouldn't, let's not get caught in the black hole of the EMR. But I do think integral to this idea of patient satisfaction, the time a provider can spend, it also speaks to team-based care. One of the other things we're trying to affect in our program in cardiac surgery now, it's not just about fixing the plumbing or fixing the electricity of the heart. We can fix the plumbing. It's looking at patients holistically and giving them a more holistic approach to their care. So part of what we hope to provide, and we're putting the pieces in place now, is to have an integrative healthcare coach meet with all of our patients while they're in the hospital, having cardiac trained psychologists meet with our patients while they're in the hospital. That helps both on the clinical side as patients embrace their disease process and own it, but it also helps on the satisfaction side because they're getting a whole other element other than a heart surgeon racing in and out saying, oh, you did fine, your valve's good to go.
And I think this, as you said, comes back very much to the team approach, that you have team providing psychosocial support in a very meaningful way at the same time that you're able to provide the medical technique.
Exactly. No one person can do it all. I'm not a psychologist. I'm not an integrative healthcare coach. I respect them. They have tremendous abilities I don't have. I can fix the valves, but I need somebody else to deal with those aspects. That's where the team becomes so critical.
Can you give us some patient examples or examples of the team working together and what you actually do in a day with a patient that's going to get a surgical procedure?
So I think one of the best examples of this is over the past 10 years, we've evolved a new mechanism for dealing with heart valve disease, something called TAVR, transcutaneous aortic valve replacement. The historic model for replacing aortic valve was to divide the breastbone. Now we do it through the groin. We can put a little catheter through the groin. But when you look at the skills necessary to do that, interventional cardiologists are very adept going through the groin with guide wires, 2D visualization with fluoroscopy. I have none of those skills. But after 25 years of replacing aortic valves, I understand the 3D anatomy, the normal valve structure, and the pathology involved in it. So by having a team-based approach, by having an interventional cardiologist and a heart surgeon at the table dealing with these patients, actually lets us do this much more efficiently, but also with better outcomes. Part of that team are nurse practitioners. The whole buildup to get that sort of a procedure done requires a village. It's not something that any one person can do.
I was going to ask about the buildup too. Do you have structured educational programs for people to go through before certain procedures so that they're learning about them and know what to expect post-operatively?
So that's a great question. It's integral to what we do. There's huge education. Probably the best model of that we've seen is in the heart failure population. So when people require transplantation or partial artificial hearts, the whole psychosocial aspect, but prior to surgery, so they understand what they're getting into, what their life can look like afterwards, both the good and the bad. So it takes very much different skill sets and many providers with those different skill sets to be part of this interaction with each individual patient.
So you have specific teams that deal with specific problems and then specific structures within those teams to achieve the educational and social outcomes that you want.
It's exactly what we have, and I think that is probably one of the biggest differences we've seen in how we provide care these days. 25 years ago, you had heart surgeons who did heart surgery. Now we have teams that focus on structural heart problems, problems with valves. We have teams that focus on coronary artery disease. We have teams that focus on heart failure. So we're looking at our patients not because of what's convenient for me and what I trained in. We're looking at our patients from their disease process and the disease point of view and how to best manage that.
And we've got under 2 minutes, but how do you assess the success of the programs?
The only people in this world I know who look at more data than heart surgery is probably baseball, with all their little statistics in the newspaper. Part of being in the heart surgery world, we look at every data point, every complication, every success, and we measure these and they're nationally reported. So we have very good nationalized data as to how well we're doing.
Do you also get patient feedback as to how well supported they felt or what educational aspects might be missing in the program so you could go back and add those aspects to the program?
All the time, and thank you for bringing that up. We do survey, we do ask, we do look for that feedback to try and figure out what we can do better.
And this is, I should point, this is not, there's no economic imperative. This is just the right thing to do, isn't it? Or what is the imperative for this change in medicine?
So I think there are multiple imperatives. There's certainly the moral imperative. Yes, it's the right thing to do. It's the way medicine should be practiced. There's absolutely a financial imperative because when we effect best care, that actually costs less and provides the most reasonable reimbursement. So that both of those come into play. And then there's the idea of if we want to recruit and retain the best healthcare providers, as are not only our patients, but our younger physicians and nurses have become more sophisticated. These are the environments they want to work in.
Yeah.
So it's a powerful recruiting tool.
People may not believe it at home, but doing the right thing and a good job for the patient actually makes you feel good. That's what you want to do.
And it costs less money. So we can use those funds to continue to build and elevate these programs. And
that's all we have time for. This great discussion, one that we could go on for a much longer time. But that unfortunately is all the time we have for today. I want to thank Dr. Richard Kaplon for joining us and thank you for watching. Please share your comments and questions with us by emailing healthtalk@nuvancehealth.org. We'd love to hear from you. I'll see you next week on Health Talk.
(145/92).
180/111.
182/100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
Heart surgery used to mean an open chest and several days recuperating in the intensive care unit. However, today, there are new options for many types of heart surgery, including minimally invasive valve surgery. We'll discuss this revolutionary, minimally invasive procedure on this week's Health Talk. Stay tuned for more with Dr. Richard Kaplon. He's the Section Chief of Cardiothoracic Surgery at Danbury Hospital. Hello, I'm Dr. Eric Mazer. On this week's Health Talk, we're going to discuss minimally invasive valve surgery, that's heart valve surgery. Our guest is Dr. Richard Kaplon. He's the Section Chief of Cardiothoracic Surgery at Danbury Hospital. Richard, welcome to Health Talk.
Eric,
so good to have you here.
Nice to be here, thank you.
I am in awe of what you do, but especially what you're doing now. Maybe you could talk us a little bit through the history of valve surgery, because it was pretty complex and pretty invasive.
It's still complex, but thankfully less invasive. So if you go back far enough, the history of valve surgery, before we had a lot of the tools and technology we had now, valve surgery started out for scarred up valves. You'd stick your hand in someone's chest and from the outside of the heart, squeeze the valve to crack it open. We then went through an evolution of replacing heart valves and trying to figure out what valves to use to replace them. We've gotten better at that. We're not perfect yet. But much of the focus over the past decade or 20 years has been on how we get to those valves. And we've been able to change our strategy from the classic needing to open the chest down the middle and open up the whole chest to replacing or repairing heart valves through much smaller, less invasive approaches.
Which is really, before we get too much further, maybe say a couple of words about what valves do in the heart so people that aren't familiar with the anatomy understand what we're talking about.
Valves in the heart do the same thing as the valves in your car engine or the valves in the plumbing in your home. They keep fluid, in the case of the human body, blood, flowing in one direction. When the heart squeezes, you want blood going in one direction, you don't want it going backwards. And so the heart valves are there to keep blood flowing in the correct direction.
And they get damaged. We don't see the rheumatic fever that we used to. That used to be a big cause of a heart valve damage. But talk a little bit about what happens when they get damaged.
So you're absolutely right. The number one cause of scarred heart valves historically, prior to universal antibiotic usage, was rheumatic fever. That's pretty unusual these days. Most heart valves that we see that need surgery are a consequence of parts wearing out. Windshield wipers work out, heart valves wear out.
And we're getting older.
That does happen.
So they're wearing out and they can leak back into the heart, or I know some of them can become plugged basically. They don't let the blood get out as well. So it can, either way, it makes the heart work a lot harder.
So the valves fail in one of two ways or in a combination. They either scar up such that they're tight and blood can't get across the valve, or the structure of the valve fails and they leak and blood just washes back and forth. Sometimes when they scar up in an open position, so you have a combination of a scarred valve that also leaks.
So again, you used to go in, and I think my era was largely artificial valves, metal valves, and then the pig valves, which were used to replace. how has that evolved? And I know that we're still doing some of those other procedures, so I don't want to say that's old-fashioned or out of date. But for certain patients, maybe say how you select them and what's different.
So there are certain patients who are candidates for different procedures. The trend has gone away from pig valves. The trend has gone away from mechanical valves. And most commonly now we use cow valves, or we use cow tissue that's manufactured into a valve. That seems to be fairly resilient and lasts a long time. Cow valves last longer as you get older, but for younger patients, under 50, under even 60 sometimes, a mechanical valve would still be the valve of choice. For older patients...
That's because they last longer?
Because they last longer. The downside of mechanical valves, they do require you to be on blood thinners.
Yeah, it gives us something to do as hematologists.
Well, if you have a reason why you can't be on a blood thinner, or you don't want the complications of, potential complications of a blood thinner, the advantage of cow valves is that they don't require blood thinners. But as we've been able to use bioprostheses, biologic valves, cow valves, we've been able to place them through smaller incisions.
Does the body reject the cow tissue at all, or is that somehow rendered not rejectable?
Great question, one I get asked all the time. So these are valves, it's manufactured out of cow tissue, but the cow tissue has been stripped of all of its proteins, so it's not seen as foreign by the human body. So there's no rejection.
You don't have to do any immunosuppression whatsoever.
No. Nope.
So talk about this idea of changing from an open sternotomy, which is just what you say. Having seen it from a distance, they literally saw down through the sternum and open it up, retract it, so you can get in at the heart and fix it. How did you get from there to replacing these valves through the arteries?
So
through the veins?
There's a couple of ways that we go to replace valves minimally invasively, and it depends upon the valve. And the way I think about this, patients come in with valve disease, and depending upon a huge number of factors, we now have different arrows in our quiver. Some patients still need their breastbone divided. For the mitral valve in particular, we can often do it through a very small incision under the right breast, going through the side, working in the space between the ribs. For the aortic valve, oftentimes we will just divide a little window into the breastbone. But probably the most common minimally invasive valve procedure we do now is something called TAVR.
That's certainly what I've heard of.
Transcutaneous aortic valve replacement. So instead of taking a cow valve and dividing the breastbone and sewing it into the heart, we're actually able to crimp that valve, pass it over a guide wire through an artery in the groin, place it inside the heart, and then expand it back to its normal size and shape under fluoroscopy with a balloon.
What do you do with the old valve? Do you have to cut that out and somehow retrieve it through the artery?
So when you do open heart surgery, either through the open chest, through the smaller incisions in the chest, we do cut out the old valves. When we go through the groin, it's very much like they do for blockages in the coronary arteries. They blow up a balloon to go ahead and push the disease out of the way. In the case of the valve, we actually expand the new valve, pushing open all of the diseased old valve.
My hematologist kicks in. Do you ever free up debris and to go and embolize elsewhere when you're pushing up the old valve, or how do you protect against that?
So I've been doing this for 25 years, and every time I do one of these, I'm still in awe of the fact that we don't embolize debris.
Interesting.
Because when I do these open valves and you see how awful they look, it's unimaginable to me that things don't shower. But we look at the data, and fascinating is that the stroke rate when we go through the groin, as opposed to cutting out the old valve, is actually almost exactly the same, maybe even a little bit better.
That's amazing.
Than opening the chest.
Now, so this patient walks in, gets a new valve. What people may not realize at home is when you've got either a blocked or leaky valve over time, it damages the heart. Putting that extra stress on the heart damages the heart. So the heart can get weaker, and ultimately can be cause of heart failure or heart attack. We used to sort of wait till fairly late stage to replace that valve because the risk of the surgery was so high that you didn't want to do it until it was absolutely necessary. With this more convenient, lower risk surgery, are we moving those goalposts or the thresholds lower so we're protecting the heart even more?
So there's two really interesting elements to this question. One is this idea of risk benefit, and you're absolutely correct. As we've been able to diminish the risk, yes, it's appropriate to intervene sooner. But as we've done more and more of these over the past 20, 30, 40 years, what we've learned is that when we intervene sooner, the recovery both from the procedure and the long-term benefit is tremendous. Classic example being...
Does that move the open procedure earlier as well?
Absolutely.
Oh, I didn't know that.
Classic example for this is when you look at a leaking mitral valve. Back when you trained, when I trained, we did not even think about correcting a leaking mitral valve until a patient was profoundly symptomatic. Mm-hmm. We now know from data longitudinal studies over thousands and thousands of patients that if you correct that mitral valve, when you identify it, even in an asymptomatic patient, that patients fall back onto a normal survival curve and a normal quality of life curve.
Wow.
So it's absolutely appropriate to correct these things much sooner in the course of the disease process.
So what you're saying, this is really not just more convenient for the patient or less invasive, it's better for the patient in a lot of different ways.
It's better for the patients in terms of how long they'll live, and better for the patients in what their quality of life will be during the time that they live.
Just for the fun of it, can you compare for our folks at home what it's like to have an open aortic valve replacement for the patient versus having a TAVR? You know, just sort of.
So having never had one, I can't exactly speak to it, but having done thousands of each. So an open heart valve replacement, whether we do a small incision or divide the whole breastbone, usually means you spend half a day in an operating room, a day or two in the intensive care unit, a few days in a normal room getting your strength back, and then you go home. But your recovery is probably 6 weeks of no heavy lifting, no driving, because the breastbone needs to heal. With TAVR, when we go through the groin, it's about the same amount of time in the operating room. You typically don't need to go to an ICU. You'll go to a step-down unit or a recovery room. From there to a normal floor room. Most patients go home the same day.
The same day?
More commonly the next day, excuse me. But
still, it's really...
But yeah, more commonly the next day. But even with that, they're home within a day. And then we're just cautious about heavy lifting. You don't want to disrupt where we entered the groin. But most patients are home and back to a very normal life almost immediately.
The valve itself, is that completely stable from the moment you put it in?
Yes.
Or is it, so it doesn't need to scar over or anything in order to heal?
It's not a healing process. So in both procedures, the recovery is not about the heart or the valve. It's about what we've had to do to make that happen. So for TAVR, it's about getting the groin to heal. For open heart surgery, it's about getting the chest to heal.
Now, we've got less than 2 minutes left. Could you put on your future casting hat? Where do you see the next advances in cardiovascular surgery?
Fascinating question.
What's around the horizon?
So right now, as we're getting better at dealing with structural heart disease, it's hard to imagine a genetic or immune modulated therapy to get rid of the structural process. I think in the short future, we will see our catheter-based interventions to replace these valves continue to improve, such that the likelihood of even needing small incisions in the chest will probably go away. I think that'll be the next evolution for
almost to 100%
treating heart
fat,
or a very high percentage.
And how about robotic surgery? People hear a lot about robotic surgery for certainly prostate and some of the groin or gynecologic operations. Where does that have a big role, do you see, or a future role in heart surgery?
So it does have a role. It's being used commonly nowadays across the country. Like any other tool, a robot's a tool. I think we're trying to understand its best application in heart surgery. We've learned from it's interesting you mentioned the gynecologist and the urologist. When you're working down in the pelvis, it's hard to get your hands down there. It's hard to see down there. The robot's been a phenomenal tool for that. In the chest, our visualization, our hands, it's actually pretty easy to get to. So we're trying to understand where the benefits are, so that we're still on the learning curve of that one.
Well, it's very exciting. It sounds like there's nothing but good news ahead for our patients, and I'm so glad to have you here. That's really very, very interesting. Unfortunately, that's all we have time for. We'll have to have you back, and there's so many other things we can talk about. I want to thank Dr. Kaplon for joining us today on Health Talk, and thank you for watching. Please share your comments and your questions with us by emailing healthtalk@newvanshealth.org. We'd love to hear from you. We'll see you next time on Health Talk.